Hi, my name is Todd Schwett. I'm a professor of neurology at the Mayo Clinic in Phoenix, Arizona, and I'm also on the board of trustees of the International Headache Society. So I'm going to talk to you over the next couple of minutes about the treatment of post-traumatic headache. So as you all know, post-traumatic headache is a secondary headache type, and it can be attributed to one of three different types of injury according to the ICHD diagnostic criteria. So post-traumatic headache, or PTH, can be due to mild traumatic brain injury, to moderate or severe traumatic brain injury, as well as to whiplash or to craniotomy. Now, the headache has to begin within 7 days of the injury, according to diagnostic criteria. Now, this is a controversial aspect of the criteria, but it's really the only evidence of a causal relationship between the injury and the headache itself. Now, it's important to note that there are no specific headache characteristics that are required to make a diagnosis of post-traumatic headache. So it's common to actually describe a post-traumatic headache according to the other headache type it most resembles. So one could say it's a PTH of a migraine phenotype or PTH of a tension type headache phenotype. Now, it can also be subdivided according to the duration that it's been present. So if it's been present for less than 3 months, it's considered acute PTH, and it's considered persistent when it's been present for 3 months or longer. Now, it's important to recognize that PTH oftentimes will resolve on its own in the acute phase, oftentimes within the first few days. However, as much as 30 to 50% of the time, it becomes persistent. And we're not really very good at determining or predicting in which patients the acute post-traumatic headache is going to become persistent. There have been some risk factors identified for persistent symptoms following traumatic brain injury, and probably some of them apply to headache as well. And these include things like gender and age and education, use of alcohol and illicit drugs and tobacco, history of psychiatric and neurologic disease. Pre-existing headache is probably a big one. So someone who, for example, has migraine prior to their injury and then develops post-traumatic headache. The number of prior traumatic brain injuries, abnormal head CT findings, injury mechanism might be a predictor. So for example, someone who has been the recipient of an assault might be more likely to have persistent symptoms. Those who have injuries outside the head, the duration of post-traumatic amnesia, as well as the presence of anxiety and depression symptoms. But despite kind of recognizing these different risk factors, we don't yet really have a calculation, if you will, to say that this patient in front of us has a X% chance of becoming persistent. If we did, that would be really useful when making treatment decisions, because it would help us to determine how aggressive we should be with our therapies. Now, it's important to keep in mind when treating post-traumatic headache that although PTH is the most common symptom, it's the most common persistent symptom, it's very frequent that there will be other symptoms that are also present in the patient who's had traumatic brain injury. And so frequently this will include problems with sleep, cognitive dysfunction, abnormalities in mood, vestibular or balance problems. There can be autonomic nervous system dysfunction, as well as involvement of the neck and other muscles. So it's important to take a holistic treatment approach to these patients to make sure that all of these different symptoms, when needed, are being addressed. It's also important to make sure that the treatments we're using for the headache don't actually exacerbate these other symptoms. So, for example, if we were to use a medication that has cognitive side effects, though, of course, if the patient already has cognitive dysfunction, that might make their symptoms worse. A patient who has autonomic dysfunction, as another example, if they have orthostatic hypotension or intolerance, maybe we wouldn't want to put them on a medicine that might have the effect of lowering their blood pressure. So how do we determine when to use treatment for post-traumatic headache? So again, sometimes it'll resolve on its own. Other times we're going to need to intervene. Well, I'll start by saying that there really aren't any established guidelines that help us to determine when to start treatment. And because we can't really reliably predict who will have natural resolution versus persistence, we just have to use our subjective judgment. And that judgment is going to be based upon the severity of the patient's symptoms, the frequency, of course, the impact that those symptoms and the headache is having on that patient's ability to function. You really want to look at the longitudinal pattern of symptoms. So a patient who's had no change in their symptoms, or of course is getting worse, you're much more likely to start therapy compared to the patient who you're already seeing some improvement in the acute phase. And then you want to, of course, watch out for medication overuse. So if an individual is requiring increasing amounts of symptomatic or acute therapies, that's an indicator that more intervention is needed to avoid medication overuse. Unfortunately, there's really a lack of evidence in the literature that helps guide us as to which specific therapies to select when treating post-traumatic headache. So there's really a lack of large prospective randomized placebo-controlled trials. There are some data that have been published for acute therapies, such as NSAIDs and acetaminophen, peripheral nerve blocks, triptans, antiemetics, diphenhydramine. There's some data for preventive therapies, such as gabapentin, different tricyclic antidepressants, propranolol, valproate, topiramate, flunarizine, melatonin, erenumab, and transcranial magnetic stimulation. But the results are somewhat mixed, and again, the quality of the evidence is low. So it's often stated that in the absence of evidence for specifically how to treat post-traumatic headache, that we should treat it according to its phenotype. So for example, if a patient has post-traumatic headache that resembles migraine because it has a lot of migraine features, then you would treat it as if it is migraine. If that post-traumatic headache resembles tension type headache, then you would treat it as if it's tension type headache. In reality, this is probably not the optimal approach, but in the absence of evidence for specifically how to treat post-traumatic headache, it's probably the best that we can do at this point. And again, it's important to treat holistically, so to address other symptoms when needed. So this might include the need for cognitive rehabilitation, vestibular rehabilitation, physical therapy, treatment for autonomic nervous system dysfunction. You might need to address mood or psychological issues, and then of course treat sleep disorders, because all these symptoms are going to interact with one another, and it can be quite cyclical, meaning that if a patient has very poor sleep, that might make their headaches worse. If they're having very bad headaches, that might keep them from sleeping, just as an example. And then some patients are going to need work and school accommodations. Now, the good news is that there are a lot of clinical trials going on currently looking at how to best treat post-traumatic headache. And we should probably think about treatments for post-traumatic headache really in at least 3 different time periods or phases. So there might be certain treatments that are best to be used in the first few days after the onset of post-traumatic headache, maybe others in the first few weeks. And then, of course, we need treatments for post-traumatic headache after it's already become persistent. Optimally, though, we'd find a therapy that would abort the post-traumatic headache in the acute phase and keep it from ever becoming persistent. So if you go online and you look for registered clinical trials for post-traumatic headache, there's quite a few, and that includes multiple different interventions. But just to list a few, there are ongoing studies with CGRP monoclonal antibodies, with botulinum toxin, with using neuromodulation, cognitive behavioral therapy, triptans, as well as others. Thank you.